I can't believe it. We are joined by the one, the only Professor Anahi Perlas. Now, I remember when I started in anesthesia, regional anesthesia, reading papers that she authored, and I finally got to meet her. What a pleasure. Thank you for coming to join us.
Thank you. Welcome, Anahi. I'll do you one better.
Okay.
I knew Anahi when she was a resident because we did
what?
residency together.
Did you really?
We did.
We weren't quite in the same year. I think you were a year ahead of me, maybe.
Something like that.
Yeah, but I knew her back when. I'm just gonna say.
Wow.
Yeah.
Okay. Well, that's okay. I mean, you have a slight advantage being over this side of the Atlantic, possibly.
Yeah.
But
I've known Jeff since he used to be Canadian.
so
That's a while ago.
That's
Okay.
right. Well, welcome, Anahi. It's so
Thank
nice
you.
to see you as
Pleasure
always.
to be here.
Yeah. Oh, great. How's the meeting going for you so far?
It's going great. I've had some sessions to be done, and then I've also had a chance to listen to panels and other people.
Yeah.
You know, it's been great, and
Yeah.
lots of networking.
Yeah.
I know that's the
Yeah.
best part.
That's
right?
a constant theme we've heard of all of the guests that we've had at this ASRASpring25 podcast recording. They've all said it's amazing to be able to interact with people and to network and to learn and engage. And it feels like, whilst there might be 1,000 people here, you're able to mix with people freely at the break times. And so you've enjoyed that. You made the most of that.
Very much so. Very much so. Yes. Big sessions, small sessions, plenty of events happening in between, and
I always feel invigorated academically coming back from ASRA. Like I have I still use pen and paper for my notebooks, right? Like, but I have little notes jotted down. Like I need to look into this. I need to read this paper. I need to do this study. Anything that's
same here really
Yeah.
resonates with me because it's the same with me. I come back to work and I feel like this is worth doing. This is why we're doing all these
Yeah.
things, you know,
Yeah.
and yeah, very much so. And ASRA is very special that way, I think.
Yeah.
It's a great community.
Uh-huh.
It's also the right size of meeting because it's large enough
Yeah.
that you meet experts from, around the world,
Uh-huh.
many different topics, but it's small enough that you actually bump into people and can have real conversations and people are so approachable.
Yeah.
I mean, from the president of ASRA to the last volunteer, everyone
Yeah.
is so amazing and so approachable. So yeah, it's a great meeting.
Yeah.
Never get tired of coming to ASRA
I know.
meetings.
I know. It's true, right? Like I haven't been to an ASA in a couple of years, but
So I've never been, but I've heard the scale of the meeting it's so
it
big.
just makes it a little bit impersonal. Like I think, unavoidably if you get that big.
But you definitely get the sense of family from here. You can look at the interaction between different individuals. You say, okay, you can tell these people value each other's opinions. They feel close, and there's a mutual respect. People working in different academic institutions, working on different projects, but it seems a really collegiate, a fun family type feeling. Speaking of family, we talk about dads and maybe dad jokes. You'll notice that that's kind of a prerequisite. And it doesn't have to be dad jokes. It could be a mother joke, an auntie joke. But essentially, we want a bad joke. Have
Okay.
you done some research and have you got something you can drop for us?
I'm going to do a quick one because people's attention span seems to be getting shorter and shorter. So the one I have is, how many therapists does it take to change a light bulb?
I
don't know where this is going.
She's laughing already. Okay, tell us.
Well, only one, but the light bulb does need to want to change.
Very good. Okay, I love that. That is in a top 3 contender. I love that.
Yeah,
that's
great.
really
Right.
good.
Glad
Thank you.
glad
you very
approve.
much.
Yeah.
So I want to get into the juice of some stuff. So we cannot have you on the podcast and not talk about one of the massive things that's happening in the world of regional anesthesia and pain medicine, which is, of course, gastric point of care ultrasound. You are one of the pioneers of this thing. You worked in collaboration with with somebody. I want you to tell us a little bit about how you became interested in it, and how that journey, between coming up with algorithms and guidelines, how did that happen? Tell us about it.
Yeah, well, I guess I was always a little bit interested in the concept of trying to prevent aspiration, having had 2 cases of
Oh.
bad aspiration early in my career, one of them as a resident, one of them as a junior staff. And I quickly realized how limited we are clinically to really appreciate what is the true risk of our patients. Sorry, I have a whole audience there. Those
Oh,
are my
wow.
fellows.
This is wonderful. Okay.
Um,
Guys, if you want to you can come and stand behind us, because then you'll get on the video. Come this way. Come round. Now they walked away.
Put your fingers up behind Anahi's head. Yeah.
Sorry, yeah.
So yes, so I got interested because of these 2 bad cases of aspiration that I had. As I was saying, I realized we're really limited clinically in our tools to appreciate what's the true risk of aspiration in our patients. It's hard to tell sometimes whether they have a full or an empty stomach, except for the extremes of risk. So it was going back to 2007 or so. I was just sort of coming back from a maternity leave, and somebody in my department had been looking at the superior mesenteric artery flow and trying to correlate that with MPO status. And so they had a data set and they had some images, and they said, do you want to look at it and see if you can make something out of it? Is something worth pursuing or not? So I started looking at it. The data wasn't telling me much, but I started looking at the videos and I said, forget the SMA. We can actually see the stomach and what's in the stomach.
That's how this started?
That's how it started.
Isn't that neat?
So this is going back to 2007. I said, we really need to look into this. So we put a protocol together. We lined up the volunteers. We gave them different things to drink. We convinced one of our sonographers, radiology sonographers in the hospital to work with us, to get us started. They didn't believe in it at the beginning, but they said, well, we'll help you. We'll work together. And then we very systematically started looking at the different parts of the stomach, different angles, different patient positions and things like that, and looked at, okay, what parts of the stomach are more amenable to ultrasound, which ones have more air or less air, which ones you can see or not see consistently, these kind of things. So we established some early metrics, and we got excited from the very beginning. We could tell that there was something in it and they could potentially be useful one day.
Yeah.
So, that was just the first study, and we got a early grant from the Anesthesia Patient Safety Foundation to keep studying this, from CAS as well. And then we went from there,
Amazing.
and one study led to the next. And then once, we had to build the tool, then we did another study to actually look at the volume size correlations. And then because it's a diagnostic test, so we had to look at the diagnostic accuracy of this, sensitivity, specificity, all these things. We had to look at reliability. If you do the test and I do the test, do we come up with the same result or different results? So we had to do that study as well. And it just kept going from there.
What an amazing story. I didn't know that first part about the SMA.
Nor did I.
Yeah, I just knew that you had done all that work. And I love that you didn't stop at like, hey, we can see the stomach and we can see like qualitative stuff in there. You're like, well, no, I want to know, is this a reliable way to precisely estimate the volumes quantitatively? And that was amazing.
And I can tell you it's been quite a journey, because the types of studies that you need to do, they're all different, and they were very new to me. Like, I had to learn, okay, I know I want to look at diagnostic accuracy. How do you do that? How do you do a study like that?
Yeah. Like, what's the gold standard to compare against?
Yeah.
Right.
Yeah.
Exactly. And my previous years in academia had been all looking at interventions, so it was all RCTs and blocks, and do these block work, and comparing one block to another. This is a completely new way of thinking. This is the diagnostic test. So how do you build a diagnostic test, and how do you evaluate a diagnostic test to see if it's good enough or not, to see if it's reliable or not, these kind of things. So it's a lot of learning.
Really, really cool.
Yeah, cool
And
journey.
at the time when you were looking at this, you had a very personal reason for pursuing it, but you weren't to know what was coming in the future in terms of medications and GLP-1 agonists and how this has become topical.
Right.
But I want to I'm always the guy that seems to ask the controversial questions here. You may or may not be aware that as we're proliferating the knowledge and the love and the joy of being able to use this as a diagnostic tool, there are always going to be some people that say, well, hold on, show me the evidence. So I asked Jeff this question. We did a whole episode on point of care gastric ultrasound after Jeff made a video. As somebody who's relatively new to point of care ultrasound and learning a bit about gastric POCUS, how do you recommend I use it? And how do I deal with people that tell me, listen, there's no evidence that this makes a difference? Because to start adopting this practice, you got to have a reason to do it. So I'm really keen to learn from the person who's innovated this.
Absolutely. Well, those are two excellent questions, of course, coming from you. We didn't expect anything different. So first of all, where's the evidence that this makes any difference? So that's a really hard question to answer, because what we're trying to prevent here is pulmonary aspiration of gastric contents, a relatively rare complication. So it's difficult to build up evidence to prove that whatever intervention is going to change the outcome of a rare intervention like this. You need many, many tens of thousands of people, and then choose the right people and choose the right patients.
We're not going to get that study out.
We're never going to get that evidence. So you need to look at a surrogate marker, which is gastric content. So to me, that is, it's very intuitive, because in anesthesia, we're thinking all the time about full stomach versus empty stomach.
Yeah.
It's in our language, right?
Yeah.
Even before gastric ultrasound, oh, this patient has a full stomach, so we need to, rapid sequence induction, intubate them, or they've eaten, so therefore they have a full stomach, we need to cancel the case.
Right.
So we're assuming these things. So we're talking all the time about empty stomach, full stomach, but so that is the outcome of question here at the moment. And this is what we now have a better way of establishing full stomach versus empty stomach, with something that is more objective and more individualized to the individual patient, other than just, the number of MPO hours, which are only really applicable to the healthy patient having elective procedures.
But even then, not all, it's so all over the place.
Right.
Mm-hmm.
Yeah. I like that. So I think we're asking the wrong question. Show me the evidence that it prevents aspiration. No. That's not the question. Show me the evidence that it can measure gastric content. That's the question.
Accurately.
Yeah.
That you can accurately determine, does this patient have a full or an empty stomach? So it actually made us generate what is the ultrasound definition, or a full stomach versus an empty stomach, right?
Because that's a different thing.
That, right? And so the way we did that was, after we had the tool built up, we started looking at the gastric content of healthy people who had fasted coming for elective surgical procedures.
Just observational.
Just observational. We did 200 patients at Toronto Western. This is way before the days of GLP-1s, and just observational. And so we found that, about half of all healthy people who have fasted have essentially no content whatsoever in the stomach, but the other 50% have some clear fluid, and it's totally normal.
Mm-hmm.
So if you have...
We assume they're empty, but they've got stuff there.
Yeah. So rather than call it empty stomach, I actually, when I write reports and when I talk to my colleagues, I say the contents are consistent with the fasting state in a healthy person, right?
Okay.
Because if you have a low volume of clear fluid, 50 mils, 60 mils, 80 mils, we put to sleep every day many, many, many patients in those conditions, assuming they are empty,
right?
LMA, no worries, and they do well. So these people, again, from this observational study, we know that 50% of people have some amount of gastric secretions. It's not a dry organ,
of course,
right? And so then we determined, okay, what is the upper limit of this normal volume, right? But that's important for when you see clear fluids. Obviously, if you see solid in the stomach, which is the first question, right? There's a first high-level question. What is the type of content? Is there nothing at all? Is there clear fluid, or is there solid? And if you have solid in the stomach, I think any of us would treat that as a full stomach.
Yeah.
I don't mind if it's a small muffin or a big bagel or a half a steak. It's a full stomach, right? And if you have nothing, you have nothing. But clear fluid is the real question. It's only you need to quantify if you're in the presence of clear fluid. And what we're trying to answer is this consistent with the fasting state and low aspiration risk, or would this put the patient at high risk of aspiration?
Right. And I love the grading system that you and others developed with the grade 0, 1, 2. It makes it really, easy and quick to make these bedside determinations rather than have to, figure out the number of mils. So that's really been really helpful, I think.
That's very interesting. That grading system came from this study, from the same study published 2011, so many years ago now, 14 years ago. And so we, because we were, it's a long story, but initially we were looking at many different parts of the stomach, and finally we narrow it down to the antrum, recognizing it's the most consistent part of the stomach to be seen. It has the least air of all the other parts of the stomach, so it's more reliable. It's easier to identify. Anyway, so we started looking at the antrum at different patient positions, and then we realized in a lot of these people, they look completely empty when they're supine, and then you appreciate a bit of the fluid when they are in the right lateral decubitus. And that is completely normal. I mean, that is so common in fasting people. So it's only when you have a distended stomach with a lot more fluid that you start seeing, full with lots of fluid in the supine position. So that's how we came with that grading system. What I really love about that grading system is that first of all, it's simple to apply.
Yeah.
You don't need it to measure anything or any formulas. Second of all, it applies similarly to lots of different patient populations. So we've studied since then. I worked with my colleagues in Mount Sinai Hospital, which is an obstetric hospital. So we did a lot of obstetric studies. We work with our colleagues in Belgium, also looking at obese people and also obstetric patients. And we looked at how these gradings distribute in the healthy, otherwise fasting population. And the proportion of patients that have each of these grades are almost identical, whether we're talking about a child, a baby, an adult, a pregnant person, a non-pregnant person, an obese person.
Yeah.
So this distribution of grades, it's applicable essentially to lots of different types of patients, very robust. And the reality is there's very, very few patients who are healthy and fasting who would have a grade 2 antrum, who would basically have enough volume that you can see it in both supine and bilateral decubitus.
Right.
So this is rare in the fasting population. So that is a first sort of sign that there may be more volume that we would like to see.
Right. I'm going to get a bit controversial, even more controversial than your question. Okay, so we've established that gastric ultrasound is reliable, reproducible, precise. It's also non-invasive, simple, and very rapid, right? All those good things. In the era of patients coming in with GLP-1 agonists on board, and we don't know the gastric status is no longer
a given.
Yeah. Is choosing to ignore gastric ultrasound a breach of the standard of care?
Well,
or should I'll ask it a different way. Sorry to interrupt you. Do we need everyone to know how to do this?
Well, that's a difficult question for me to answer because I'm too invested in this topic. When you've studied a topic enough for 15 years, you very easily convince yourself that it's the center of the world and everything needs to go. So it's not for me to say. I think it's for others to say. What I can tell you is that in the last 6 months, we've had some guidelines published in North America, guidelines published in the UK, guidelines published in Australia, all relating to how to manage GLP agonists coming for surgery. And they all vary in the details
I was
as
going
to
to say,
what do we do with the drug, how many hours of fasting do we need. They all vary, but they all recommend one thing in common. When in doubt, use gastric ultrasound, and
that's
that is
so
going to
true.
help you sort out the situation.
The guidelines are not consistent in what they tell you to do with how to manage the medication perioperatively, but they all mention gastric ultrasound.
Right. So we have 3 in the last 6 months: North America, or US more specifically, UK, and Australia.
Yeah.
So it's certainly brought a lot of attention. Again, gastric ultrasound is not new. It's been brewing behind the scenes for a long time. But I think what the GLP-1 agonist situation did, it brought to the light a very immediate reason to use it. Now,
Yeah.
I think it goes well beyond that. There's many other situations in clinical practice in which, based on clinical grounds, the risk of aspiration is not clear. Patients who are coming for urgent procedures, they may need way longer periods of fasting than your elective patients. Patients with severe diabetes and confirmed gastroparesis, patients with Parkinson's and other neurologic conditions. So there's a lot of situations in which the standard fasting guidelines may not be sufficient, and you may have questions about MPO status. So it goes well beyond. But I think the GLP-1 agonist is something that everyone is exposed to at the same time all over the world, and so it brought suddenly a clear situation in which this could be helpful.
Yeah, I agree. And then what's interesting is we have used this to answer a different question, which is, oh, we just found out so-and-so ate at 6 a.m., but the patient ahead of her didn't show up. So can we, move the case forward? But it's only been 3 hours. And before this, we would have said, sorry, you have to wait 6 hours total. But now put the probe on. And lo and behold, many times, oh, guess what? You're actually fully empty.
Yeah.
And so it's accelerating, and it's just making clinical decision making. You're relying on an objective tool rather than a guesswork and a.
Absolutely. I had a patient last week who was having surgery. For some reason, she woke up at 3:00 in the morning very hungry, and she had some fried.
That happens to me all the time.
Anyway, she decided to have for a snack a plate of fried calamari and some fried chips at 3:00 in the morning.
I want to meet this woman.
Wow.
So she was badass woman. Anyway, so and then it was kind of borderline. It was around 7 hours after that. It was like 10:00 in the morning, but it was fried calamari and chips, right? So the question was, is it safe to proceed with this thing? Should we proceed, or should we postpone, or maybe leave it till the end of the day or something? So we scanned her stomach, and sure enough, she was still full.
Oh my goodness.
So we decided to change the order of the list and wait till the end of the day. We scanned her again, and then she was empty, and then we could proceed, but several hours later. But if she had been empty, because then we would have proceeded just fine.
Okay, I want to finish up on asking one more question. So, do you have experience of having an answer, having a scan, say, right, there's content in the stomach, and then giving a prokinetic agent, and then going back to scan them again afterwards? Is that something you do? Is that something you'd recommend? Do we need to know more about this? Do we need to research more about this?
I think it's a reasonable thing to do. I haven't systematically looked at it in the form of a study on prokinetics themselves. I have used it, though, on one of the studies that we did over the years at Toronto Western was we looked at patients who had eaten in the morning something before elective surgery. And so we looked at whether gastric ultrasound helps to change management in any way. And when the patients presented with full stomach and having eaten, we would put them on a prokinetic, send them for a walk, and rescan them a few hours later. And I mean, some of them would empty, some of them wouldn't.
Okay.
So it's on a case-by-case basis. Right. I think it's a very reasonable thing to try, though. There's very little downside, so why not?
Yeah. Okay, interesting. Listen, I think I'm going to remember hearing about how you conceptualize the whole idea. That's brilliant. So thank you for sharing that story with us. Thank you for taking the time to join us on the podcast. We're really honored to have you here.
Amazing. Thank you, Anahi. And thank you for the dad joke too.
Yeah, that was next level. And
Well, I was thinking I need a short one because people's attention span is not what it used to be, including my own.
I even remember the punchline, the light bulb has got to want to change. Yeah, I love that.
Otherwise, there's no number of therapists that's going to do it for you.
I'm going to take a selfie of us if that's okay.
Let's do it.
Nice.
Thank you so much.